All attendees are in listen-only mode.
Greetings and thank you for joining us for today's webinar called The Science and Practice of LSVT Big. My name is Laura Gousset and I'm one of the LSVT Big instructors, and we're delighted to have you here today for what we hope was going to be an informative webinar for you. Before we go any further, we would like to acknowledge our funding support that has made LSVT Big and LSVT Loud possible and what they are today. And we have received funding from the Michael J. Fox Foundation, the Parkinson's Alliance, and the Davis Finney Foundation, among others. So I briefly want to go over the plan for today's webinar. If you haven't joined us for a webinar before, we're going to go over some of the logistics. After that, I will begin the webinar today and give you a background on LSVT Loud and LSVT Big and their development and rationale. And then Beth is going to delve in more specifically about what the LSVT Big protocol is all about. At the end, we're going to discuss some resources that are available to you, whether you are a person living with Parkinson's, a health professional that is not yet certified in LSVT Big, or if you are just simply a caregiver or someone interested in helping people with Parkinson's disease. At the end, we'll try to leave some time for questions as well. So in terms of logistics, right now everyone in the audience is automatically muted so that there's no background noise from the various environments from which you might be joining us. But at the end of the webinar, like I said, we will have some time for questions. And I want to go over 3 ways that you can ask questions during that question and answer time. The first way is to type in your question. You'll see a control panel probably on the right side of your screen, and there's an area that says questions. You can type your question in there, and when we see your question, we will read it out loud. It will not have your name included. It'll be anonymous, and either Beth or I will answer the question. The second way that you can ask a question is by raising your hand. And to do this, you're going to click on the hand icon. When we see that someone's hand is raised, we'll call out your first and last name to know that you're being called on, so you can so we'll unmute your microphone. In order to use the raise your hand icon, you do have to have a microphone built into your computer or laptop that you're using. So if it's not working to raise your hand, please type in your question in the question box. The last way is that you can email us. If we run out of time for questions today, or if you prefer to just ask us after the webinar, you can email us at any time at info, as in information, at lsvtglobal.com, and we'll be happy to respond to any questions that you might have. Hopefully you received the handout for today's webinar ahead of time. I believe it was emailed to all the registrants yesterday. However, if you didn't receive the handout and you'd like to print it, you'll notice on the control panel that there's a little area that says handouts. You can download that and print it in case you want to take notes or keep it for more permanent reference. This webinar will be recorded and available on our website in about 2 to 3 business days, and you'll find it under the Patient Resources tab on the main home page of our website. Once you click on Patient Resources, you'll see webinars, and you'll be able to find webinars that are listed on demand. And that means that they've already been recorded and presented earlier this year. So in addition to this webinar being available on the webinar and on the website in several days, please check out our website because there's a whole host of other webinars on different topics that you might be interested in. Those are all free to you. They're all about 1 hour long, and you can listen to them at any time. So now I'd like to give you a little bit of information on Dr. Beth Marcoux and myself, who are the presenters today. I myself am a physical therapist and have been so for about 18 years. The bulk of my career, I've been pleased to be able to work with adults with neurodegenerative disorders and other neurological conditions, and that's really been my passion. I've been certified in LSVT Big since 2009 and saw an amazing change in the patients that I provided this treatment to. In 2011, I was fortunate enough to be selected as one of the instructors, and so now I'm able to go around the world along with Beth and teach other physical and occupational therapists in how to deliver this very efficacious treatment. And now I work full-time for LSVT Global as the Chief Clinical Officer of LSVT Big. Dr. Marcoux joins us. She graduated from Russell Sage College and now she lives up in New England where she's retired but continues to be extremely busy in a variety of consulting projects. She's worked for a variety of universities in the physical therapy programs, and now she is also LSVT Big certified and one of our excellent LSVT Big instructors. And so we thank you, Beth, for joining us today. We do disclose to you that we both receive lecture honorarium and travel reimbursement from LSVT Global, and I myself an employee of LSVT Global. So here are the objectives of today's presentation. We're going to briefly go over the advances in neuroscience that have made an impact on the field of rehabilitation. We're going to briefly talk about LSVT Loud because that is a speech treatment from which LSVT Big was derived. And then mainly we're going to spend most of our time talking about the development, data, and exercises of LSVT Big so that you can learn more whether you're a patient or a person interested in Parkinson's disease. So with that, I think we're just going to jump into today's presentation. Now, if you look back 20 years ago and you're in the healthcare field, you realize that it is really an amazing time to be in rehabilitation today, and healthcare has changed. And I think we all realize that, whether we're a consumer or a provider in the healthcare arena. We've learned a huge amount about the body and about the brain, and it's an exciting time as a professional, and it's an exciting time as a patient compared to maybe 2 decades ago, when a person with Parkinson's might have gone to the doctor and been given a prescription to help with symptom management, but was never referred to physical therapy, occupational therapy, or speech therapy for Parkinson's disease because simply we didn't know if they were helpful or effective. And so classically, patients were referred to therapy only in the later stages of the disease and secondary to complications such as problems with swallowing, severe problems with voice, problems with falls, difficulties with activities of daily living like dressing or toileting, but never to treat the primary symptoms of Parkinson's disease. And this is what is really exciting now, is that we have found that exercise has the potential of improving brain functioning. We call that neuroplasticity, and may in fact slow disease progression in Parkinson's disease. And so it's very exciting for us as rehab professionals to realize the value of what we do is not just about strengthening muscles or providing improved balance or range of motion, but really the exercise that we prescribe for our patients can impact the course of their disease and can improve brain functioning. So it's very, very exciting. And I think as patients, it's a very exciting consideration as well. Physicians have also embraced this, and so now more and more physicians, especially neurologists and movement disorder specialists, are referring patients with Parkinson's disease to therapy immediately after diagnosis because they realize the powerful impact that it will have. Furthermore, the research has identified key principles of exercise that drive activity-dependent neuroplasticity. So now we know more specifically what are the key ingredients that are really necessary to drive this brain change. Is it any type of exercise, or specifically what type of exercise does it need to be? Lastly, the summary statement is that it has all led to the statement of exercise is medicine. What you do in terms of medical management is very important, but the exercise that you partake in if you have Parkinson's disease has a medicinal or pharmaceutical-like effect on your brain. So now it's not just pharmacological treatment or neurosurgical treatment. If you really want to optimize symptom management for Parkinson's, it has to be a triad or at least a dyad of those two. It has to be the best and most optimal pharmacological management combined with voice and body exercise that is very specific to Parkinson's disease. So I'm going to show you one video, and you might have seen this video before because it's on our website under the videos tab, but I never grow tired of looking at it. This is a case of a gentleman named Bernie that had Parkinson's disease, and at the time the video was taken, he was in the middle stages of the disease, called stage 3 on the Hone and Yar scale, and that's a 1 to 5 stage scale that monitors disease severity and disease progression. So Bernie had Parkinson's for 14 years, and he was referred to therapy because he was having some changes with his walking. He was having problems with his balance, causing some falling. He was having freezing, and this was why he was referred to therapy. And so he underwent LSVT Big, which is a 4-week treatment protocol that we'll be discussing today. You're going to see a video of him in a moment at the start of his LSVT Big treatment and then 4 weeks later at the end. And just so that you know, he was optimized on his Parkinson's medications at the start of therapy, and nothing in his medication changed over the 4 weeks. Additionally, he was videotaped at the same timing in his medication cycle. So what you're going to see is purely because of the behavioral treatment effects of the treatment. So this is Bernie. It might be a little bit choppy on your screen because of internet speeds and your various environments. But what you're going to see is on the left side is him prior to LSVT Big, and on the right side on his last session when he was walking out the door. So I think you see immediately that he's walking faster. He is not using his cane. And the result of this improved speed is that he's able to cover a lot more ground in the same amount of time. Going back to the left side of the screen, you'll see that he really has some difficulty crossing through that doorway over the rug. And those are very common freezing triggers in patients with Parkinson's disease that can lead to falls and fear of falling. So you can imagine if he's walking that slow and with that small of steps, how that might impact his ability to engage socially with family, to keep up when he's going shopping, to go out to dinner, and so on. And whereas on the right side, he's able to walk much faster. Okay, so here are Bernie's case study outcomes. He went from falling to not falling. You saw that he did not need to use his cane post LSVT Big. And you can see that his gait velocity went from about 30% of what was normal for his age to about 100% of what was normal for his age. So this is really fantastic to be able to keep up with your peers, because now you're walking the same speed as your friends that are the same age that don't have Parkinson's disease. All of these objective outcomes led to his ability to meet his goals, which was to improve his walking, go to the movies, play with his grandkids, and go out to dinner with his friends and family. And I think Beth would agree too that this kind of outcome is very typical and very achievable of what we normally see with our patients at this stage of Parkinson's that go through LSVT Big. We want to give you a little bit of background about where this all began. One of the first questions that many people have is, what does the acronym LSVT stand for? So the L and the S stands for Lee Silverman, because Lee Silverman was a woman that had Parkinson's disease back in the late 1980s. Her family's wish was that if we could only hear and understand her. And her family helped to provide some of the initial funding that started the research on LSVT Loud, which is this efficacious speech treatment upon which LSVT Big was based. So back in the late 1980s in Scottsdale, where Mrs. Silverman lived, was where this pilot data initially was collected. And over the years, Dr. Lorraine Ramig, who was the developer of LSVT Loud, really spent her whole entire career investigating LSVT Loud, and has now become today, after 25 years and about $8 million worth of NIH-funded research, the gold standard for speech treatment in people with Parkinson's disease around the world. So there's been hundreds of research studies that have been done on LSVT Loud. You can see that in the phase 3 studies, they established the treatment efficacy of LSVT Loud. They looked at the spread of effects. They even did some neural imaging studies. But what was really fantastic is that Dr. Lorraine Ramig and her team with LSVT Global also decided that it was very important not to just keep this in the research world, but really work hard to get this efficacious treatment in the hands of clinicians and then ultimately patients who needed the treatment and who would benefit from the treatment. And so much work and time and effort has been focused on developing these training programs called the LSVT Loud and LSVT Big training and certification programs that we have launched all around the world over the last 20 years. She's also developed technology to help improve the delivery of LSVT Loud through the eLoud and through a software system called the LSVT Loud Companion. And lastly, we've begun to look at application to other neural disorders such as Down syndrome and cerebral palsy. So I mentioned that LSVT Loud has now become the global standard for speech treatment, and to date we have trained over 14,000 LSVT Loud certified clinicians in 62 countries around the world, and 7,000 LSVT Big certified clinicians in 31 countries around the world. And that statistic is just to be about updated, since that is 12 months ago that was published. But it's really an exciting thing to be able to make an impact on people with Parkinson's globally. Something unique about the LSVT programs is that they're administered in an intensive manner. Traditional therapy can be less intensive, maybe 1 or 2 times a week, but the LSVT programs are 4 times a week because we want to challenge that impaired system in order to improve it. What's also unique about the LSVT programs, and by that I mean LSVT Loud and LSVT Big, is that they're very specific to Parkinson's disease in their development. They target bradykinesia and hypokinesia, which means slow movements and small movements, and kinesthetic awareness, which is a sensory deficit that's associated with Parkinson's disease. So we're going to talk just a little bit further about that. The target of the LSVT Loud program is amplitude, because we realize that Parkinson's disease causes progressively over time the voice to get softer and softer and more difficult to understand. One of the key things that Dr. Ramig found in her initial studies was that if you focus just on one target, a singular target of loudness, there is a spread of effects that occurs. And so when someone talks in a small voice, you can see that many things happen. Their mouth doesn't open very much. They don't use their facial muscles and articulation muscles very much. There's not much breath support. But if you ask someone to speak in a louder voice, without any additional cueing, there's many different things that happen. The person takes a bigger preparatory breath, they open their mouth more, they engage their muscles in their face and their articulation system, and out comes a more healthy loudness, even though the only thing that was cued was talk louder. The mode of the LSVT Loud program is it's intensive, and so this is a brief snapshot of what goes into this intensive treatment session. On the first half of the session, the patients do what are called daily tasks. They do something called a sustained ah, where they say ah for as long as they can, a minimum of 15 repetitions to really build that vocal endurance of keeping their voice at the right threshold of sound pressure level. They do something called highs and lows, where they go as high as they can and as low as they can with their ah. And then they do functional phrases. So for each patient, these are specific. The therapist would interview the patient and say, name 10 things that you say every day. And the patient might say, well, I say good morning to my wife. I say, I love you. I say, what's for dinner? And they list those frequently said phrases, and the patient practices them repeatedly in their louder, more normal, more healthy voice. So those are kind of the building blocks to improving voice. And then on the bottom half of the screen, you see a phrase called hierarchical speech tasks. And this is where that louder voice is now translated into function in a progressive manner. So week 1, the patient will work on speaking words or phrases that are simple in their louder, more healthier voice. Week 2, progressing to sentences. Week 3, reading a whole passage. And week 4, now can you keep your voice at normal amplitude while we're having an off-the-cuff conversation and there's background noise and you're not prepared for it. And so the ultimate goal is that our patients would be able to recognize the effort that's needed to produce a more normal voice that can be heard, that's neither too loud nor too soft, and use that in everyday life. In order to achieve that, we have to achieve a goal called calibration. One of the interesting findings that was found early on when researching LSVT Loud is that there's a mismatch between the perception of the output and how others perceive it. Many times patients with Parkinson's initially come into their first treatment and claim that they don't have a problem with their voice, but that their spouse just needs a hearing aid because they're not able to recognize or sense that their voice has become too soft. And initially, when we're training patients to speak in a healthier, more normal voice, it feels too loud to this. It feels like they're shouting, even though they're not shouting. And so it takes a lot of work and a lot of repetition and feedback in order for the patient to recognize the correct amount of effort so that their voice is indeed normal, even if it still feels too loud to them. One of the key randomized control trials that established this level 1 evidence on LSVT Loud was a comparative trial looking at LSVT Loud in the red line on the top with a dose-matched respiratory group. And each treatment arm was delivered 4 times a week for 4 weeks. 60-minute sessions. They were given the same care and compassion by the therapist. The only thing that differed was the target. For LSVT Loud, it was amplitude of voice. For respiratory group, it was intensive respiratory exercises. On the vertical axis on the left, you see SPL rainbow. That means sound pressure level, or the decibels of loudness, while they're reading a standardized passage called the rainbow. The length of treatment was 4 weeks, and so you see this nice spike in amplitude in both groups actually, but the LSVT Loud group reached statistical significance, whereas the respiratory control group didn't. Then they followed these 2 groups out at 2 months, 6 months, 12 months, and 24 months, and that was the endpoint of the study. And although the LSVT Loud group got a little bit softer, they never went back to baseline, and they still remained statistically significantly louder than the respiratory control group, who essentially went back to baseline. And that was without any further treatment. In the normal clinical treatment world, we would see people periodically, usually every 6 months, for a short tune-up to help maintain that treatment effect to a little bit higher level. But this was very exciting to know that we were on the right track in terms of the treatment target and that treatment results were long-lasting. Over the years, LSVT Global and others have done a wealth of research establishing this spread of effects that occurs as a result of LSVT Loud. They've done imaging studies. They've looked at how LSVT Loud impacts swallowing, aerodynamics, respiratory kinematics, acoustics, articulation, facial expression, and many other things that aren't listed here. And so it just drives home this point that if you target the singular target of loudness or amplitude, there are many, many things that improve in the person. So in the late, actually around the year 2000, after LSVT Loud was really established in terms of its clinical efficacy, the question arose that if this works so effectively for the speech motor system, could this also be applied to the limb motor system? And at that time, Dr. Cynthia Fox, one of our co-founders of LSVT Global and an LSVT Loud instructor and expert, was working on her PhD with a physical therapist by the name of Dr. Becky Farley. And together they worked on this translation from LSVT Loud to LSVT Big, which is the physical and occupational therapy treatment protocol. So the fundamentals of LSVT Big are this: it's standardized, just like LSVT Loud. It's research-based. It's based on the research of LSVT Loud and carries its own independent research. And it's a specific treatment protocol, which is very much customized to meet the needs of each and every patient. And Beth will briefly go over that today. So instead of focus on amplitude of voice, we focus on amplitude of movement. So arm movements, leg movements, you can think of amplitude of posture, not being flexed, but being in a more upright posture, and even amplitude of fine motor movements like finger movements needed for handwriting or buttoning. The mode is also intensive and high effort, and it's delivered 4 times a week for 4 weeks. And our goal is sensory calibration. And so we focus on overcoming these barriers of the perception of what movement is like, the ability for a person to remember to use their bigger movements in everyday life, and also we address these barriers of neuropsychological changes that can occur as well. So this is just a treatment sketch that was given by a person that went through just a stimulability session of LSVT Loud or LSVT Big, and you see his perception before treatment is that he's shuffling, and after treatment there's this spread of effects. He's not only having bigger stride length and bigger arm swing, but he's smiling. And so just like with LSVT Loud, there's this nice spread of effects. We see improvements in movement, we see improvements in balance, we see improvements in posture, in speed, and so on. So just one moment, please. Okay, so this is the mode of LSVT Big. It's always delivered by a therapist that's certified in LSVT Big as a one-on-one intervention. The time of practice is 4 times a week for 4 weeks. However, some patients need a little bit longer than that. Our sessions are 1 hour long, and our patient has daily carryover assignments and daily homework assignments as well. From day one, we work on calibration as well, that there's a mismatch between the perception of output and how others perceive it. So interestingly, when patients move small, they don't always perceive that their movement has become too small until we show them. And at that time, they sometimes give statements like, I had no idea how small my world had become. And when we get them initially moving more normally, it feels too big to them. And it feels like if I move like this, people are going to think I'm crazy. So it takes a lot of repetition, a lot of feedback in order to overcome those barriers. So pre-treatment, patients come in with this reduced amplitude of motor output from their brain because of the changes in the brain from Parkinson's disease. Because of this, their movements come out too small and too slow, but there's a problem with being aware that the movements are too small and too slow. There's problems with being able to cue oneself or remember to use bigger movements, and so it's somewhat of a vicious cycle. With LSVT Big, we stimulate patients, we drive them to produce larger movements, we improve their self-perception through lots of feedback, lots of videotaping, so that they know the right amount of amplitude to produce normal movement. And very repetitively and very intensively through that training, we work on the patient's ability to then internally cue themselves to habitually scale movement that is more normal. So I'm going to go over a little bit of the data on LSVT Big. One of the key studies that was done, we affectionately call the Berlin Big study, that came out of Berlin, Germany in 2010. It was published in Movement Disorders by Dr. Ebersbach, and the primary treating therapist was Olaf Kaufhold, who is now one of our LSVT Big instructors. At that time, there were 60 patients that Olaf treated. They were randomized into 3 groups. 20 were in the LSVT Big group. You can see on the left, 20 in the Nordic Walking group and 20 in a home exercise program group. So the Nordic Walking group and the LSVT Big group each received 16 sessions of therapy. One of the differences is that the LSVT Big group was delivered 4 times a week for 4 weeks following the LSVT Big protocol. The Nordic Walking group was twice a week for 8 weeks, so 16 sessions total, hour-long sessions doing Nordic walking. And in that Nordic walking, they really focus on big posture, big arm movements, big leg movements under the direction of a therapist, but it's a group treatment, not a one-on-one individual treatment. The home exercise program group was unsupervised. They were instructed to do Parkinson-specific exercises on their own every day, and they were given a specific program to follow. The primary outcome measure that was looked at was the UPDRS motor score, and this was a blinded rating. Now, on this UPDRS scale, a decrease in the number indicates an improvement or a decrease in severity of those Parkinson's motor symptoms. On the top, you see a solid line, which is the home program group, and a dotted line, which is the Nordic Walking group. You can see that both of those groups actually deteriorated somewhat in their UPDRS motor score, in that it went up by about 1 point at the end point of the study, which was 6 weeks. The Nordic Walking group did not improve in their UPDRS score at the stop of that treatment delivery, which was at 8 weeks. It was only the LSVT Big group that improved, and that amount of improvement was about 5 points on the UPDRS motor scale. So it was very exciting to see that you could make improvements in the primary motor symptoms of Parkinson's through LSVT Big. Also interesting is that the LSVT Big treatment stopped at 4 weeks. However, that score continued to improve all the way to 16 weeks, which was the end point of that study. So you might ask, it seems like I think of big movements in terms of, big arm movements or big leg movements needed for walking, but what about fine motor tasks? Because so many things are difficult, like buttoning or handwriting or stirring or brushing your teeth with Parkinson's disease. So how can you be big with small tasks? And I think the bottom line is to recognize that even small movements, fine motor tasks, become much too small in people with Parkinson's disease. And that's why we say it's micrographia, because it's tiny writing, and the finger movements needed to produce buttoning become very, very tiny. And so what we do with LSVT Big is simply stimulate that person, drive them to produce hand and finger movements that are not these huge exaggerated movements, but big enough to be normal and big enough to get the job done in a normal, efficient time. So with that, I'm going to show you this. I almost forgot about this. This is just also an example of improvements in fine motor tasks that can be seen after LSVT Big. In this example, on the left side, you see a list of things that were difficult for a patient that had Parkinson's disease. He wrote this list down prior to receiving LSVT Big. At the last session, his therapist held the list in her hands and gave him a blank copy and said, I want you to write these words down because you're going to rate your difficulty on them again. These are the things that were difficult for you at the start, and we're going to see how it was. So he simply wrote these words down that she dictated to him. Writing was never trained. It wasn't a trained task. But I think what you can see here is that the writing became much bigger, much more legible after LSVT Big because of this spread of effects that we see not just with LSVT Loud but with LSVT Big as well. So it's very exciting to see these changes that can be made in people with Parkinson's disease. With that, I'm going to turn it over to Beth, and she's going to talk to you about the LSVT Big protocol.
Great, thanks, Laura. So just want to spend some time talking to you about what's exactly involved in getting LSVT Big treatment. So next slide, please. Overall, Laura has explained to you that it's a treatment that's done for 4 consecutive days a week for 4 weeks. So you're in treatment for 1 month for a total of 16 sessions, and each session is individual. It's one-on-one, one therapist to one client, and each session lasts for 60 minutes. So it's a fairly intensive program and done in a fairly short amount of time. Next slide, please. This next slide shows you an overview of what the treatment protocols is and what each session looks like. So on the left-hand side of the screen, you see a list of 7 exercises, and these are referred to as the maximal daily exercises that we ask clients to do every day for the rest of their lives. And we're going to show you what those exercises are. So the first part of the treatment takes up, when you're first starting out, about half an hour to get through the exercise that we've identified. These exercises are really important because they're the building blocks for all movement. The next part of the treatment is called functional component tasks, and these are 5 things that your therapist will sit down and help you work out, things that are important to you to be able to continue to do. One of our therapists always asks, what brings you joy in life? And so typically that might be something like getting outside or walking with my colleagues. So you identify 5 things that are important to you, and you do those things every day, and you do each thing 5 times. So for example, everyone does sit to stand because we get up and down from meals, up and down from a chair while watching the TV. We go in and out of the bathroom. So sit to stand is a really important functional component tasks that everyone does. But other things that might be important to you, like opening a flip phone or pulling keys out of your pocket or putting on your jacket or pulling on your socks, whatever is important to you is a task that your therapist would work with you on. So those are single component tasks, standing, sitting to stand. The next things that we work on are called hierarchy tasks, and these are more complex movements and involve multiple pieces to complete the task. So an example might be getting in and out of bed, and that would involve taking off the covers, rolling to the side, sitting up, and then coming to standing. So you can see there are 4 or 5 pieces to each of these hierarchy tasks. Another might be getting back to playing golf. If you're still working, it might be putting things in a file cabinet. If you're a young onset, it might be getting your kids in and out of a car seat. So again, those hierarchy tasks are specific to the individual client, and we work to have you build that skill over the 4 weeks, and we make it harder and harder, more challenging, and putting it in different situations so that you should be able to do those tasks not only in the clinic or your home, but also out in the real world wherever you may be functioning. And a part of every session also includes what we call big walking. And this is just walking with a good arm swing and normal stride length so that you can maintain the function and be a community ambulator. So that's just a brief overview of what the entire treatment session looks like. The next slide shows you the first 2 exercises. They're called maximum sustained movements. The first one is floor to ceiling. These are both done in sitting. And the next one is called side to side. And I believe we have a video of each of these. Next slide. So you're going to see the first video, maybe a little choppy, is the floor to ceiling exercise.
Yeah. Beth, I think we don't have videos because they don't play too well.
Okay, so you can see the exercise just involves big arm and big leg movements where you would touch down to the floor, bring your arms up to the ceiling, and then you come back to the position that you see Jenny in right there, and then finally you would touch your hands to your legs. The next one is a side to side movement, and you can see that Jenny is stretched way out with her leg fully extended and her foot on the toes on the floor, and you can see from this one that this is a great stretch. A lot of patients with Parkinson's disease tend to be sort of forward and flexed in their posture, and so this really helps to increase your extension and also helps to give you some balance because you're sitting on the edge of the chair, so it moves you into a more precarious situation. We can make all of these exercises either easier for you or harder for you depending on what your stage of Parkinson's disease. All of them are done, these are maintained, sustained movements because often you would have to stand for periods of time. It might involve singing, it might involve sitting at the table to eat your dinner, it might involve sitting and typing, so sustained posture and sustained movements are very important. The next three exercises shown in this next slide are done in standing. The first one is taking a step forward, a big step forward and step back. That's an important activity for stepping into the shower, stepping up onto a sidewalk. There's lots of functional activities related to taking a step forward, stepping forward into a cabinet to reach for something. The picture, can you go back one slide? You'll see the middle picture is a step to the side, and that one is really important if you're working in the kitchen and you need to reach from the stove and to put something over on a counter. Lots of functional activities related to it. The third picture that you see is stepping backwards. That's probably one of the most difficult ones for most of our clients, but also stepping backwards is a time when a lot of patients tend to lose their balance. So this exercise is especially important for things like if you want to open the trunk of your car, reach in for the groceries and step back, to turn, to walk away. Those are all exercises that are the fundamentals or the foundations of all the movements that we do, and we train you to do them so that you become very good at doing them. Your balance improves, your strength improves, and your likelihood of falling reduces. Next slide, please. So again, you're going to see the forward step exercise that we just talked about. Again, it's great for stepping up onto a curb, stepping into a shower, stepping forward into a pantry to get something from the closet. The next slide shows again the side step to the side exercise. Again, reaching for an activity or an object on the stove, or if you're cleaning out the dishwasher, stepping to the side to put something away. And the third one is the backward stepping, and again, great for stepping out of the shower, stepping away from backing up to sit down in a chair. And all these three exercises, all of the exercises, are done repetitively, 8 to 10 to 12 times, so that you practice the movement over and over and over until you can't get it wrong. Next slide, please. The final two exercises in the 7 maximum daily exercises are the multi-directional repetitive rock and reach exercises. And the first one just starts with one foot in front of the other, and you're just sort of rocking back and forth and then raising your hands. And finally, once you've got the rocking back and forth going, then you add your upper extremities so that you're rocking and reaching. This is a great exercise for learning how to shift your balance and weight shift forward and back, so that you don't have you'll reduce again your risk of falling as you lean forward to pick up something on a table, or lean back and turn to do something else. So again, these are the foundations of all movements. The last one, the sideways rock and reach, is great for trunk rotation. So they're actually asking you to stand forward and then turn and rock and look over your shoulder and behind you. This is great for, lots of my clients have said how they've really improved their ability to turn and back up a car for those who are still driving. So it just really does wonders. All of them are wonderful activities just to increase your overall health, but also to improve your function. The next slide, again, just shows the multi-directional rock and reach, forward and back rocking and reaching exercise. And the next slide again shows the sideways rock and reach, one that we've already talked about. So all of these, again, next slide, to emphasize them, these are the stepping stones for good big movements in your daily life. If you get these, if your ability to perform these exercises is improved, then your function and your ability to move through your day will also improve. They are designed to facilitate things that we already do in life. So again, that first, the rock and reach one, you can see this next slide. Rock and reach is great for the big walking if you want to walk with your dog. All of them are based on function. So again, it's important to get these fundamental exercises, fundamental movements down to help improve your function throughout the day. So next slide, please. The functional component tasks we talked about. So that first half of the treatment session is those 7 maximum daily exercises. All of them are the fundamentals of basic movements that we make throughout our day. All of them are designed to improve your function. The next component of the treatment session is the functional component tasks. Again, these are patient-driven. So you talk to your therapist about things that you aren't able to do anymore, or things that you aren't able to do as well as you'd like to do them, or things that you never want to be able to lose the ability to do. And one that we always include for our patients is the sit to stand big. And in this picture on the slide, you can see Jenny reaching forward big. She's going to stand up tall big, and then she's going to reach forward big and sit down again big. It's a little different for if you're a therapist listening to this. It's a little different than what we've asked patients to do in the past. We always ask them to sort of lean over and reach for the arms of the chair. And when we did that, the patient would plop back into the chair and almost tip it over. So what we know now is that we need to get our weight forward in that weight forward shift so that when we lower our bodies down to the chair, we're not flopping backwards and almost tipping over the chair. So everyone does the big sit to stand. Then depending on your needs and your lifestyle, you identify 4 other component tasks that you want to do. I had a great one. A client wanted to be able to pour his own glass of cognac in the evening. So one of his component tasks was to reach up for the glass that was up on the shelf and put it down on the counter. So we just practiced that 4 and 5 times, and he would reach up and put it down on the counter. Again, picking functional component tasks that are going to stimulate the patient to think about moving big throughout the day is a really great idea. So if your patients, the first thing they do in the morning is have a cup of coffee, having them practice pouring that coffee big or reaching up for the cup, the mug to bring it and down to the countertop so they can pour their coffee, anything that you can get them to do that's an important activity in their life and something that's going to cue them to move big for the rest of their day. So you can see there are some examples on the slide. Sit and reach, walk and turn, those kinds of things. So again, it's patient-driven. You talk to your therapist, you work through what are the things that you need to be able to do better or that you want to maintain the ability to do. And remember through it all, next slide please, keep thinking big. So patients just need to think big in all their activities. If you're going to reach up to get a coat off the coat hook, reach big for that coat. If you're going to get a cup of water or take a bottle of water, you're going to turn that cap big to untwist that cap off the bottle of water so you can take a big drink. So everything is focused on amplitude, amplitude, amplitude. That's just the one focus that we have throughout our treatment sessions. Next slide, please. So we've talked about the maximum daily exercises, which is typically the first part of the program. We've talked about the component tasks. Those are functional, one-step functional components that you practice on doing. And then the third piece of the program is the hierarchy tasks. And those, again, are patient-driven, but they're more complex activities. So you're putting 2 and 3 steps together. And again, these are real-world tasks that you want to be able to continue to do. It might be getting up out of your chair, opening the door, walking to the mailbox, getting the mail and bringing it back to the house. It might be getting out the vacuum cleaner to go ahead and vacuum the floor. It might be going hiking with your friends, or it might be gardening. So you need to be practicing putting on your gardening gloves, getting down onto the ground, using a trowel to dig out a hole. So all those things would be activities that you would work on for that goal of being able to garden again. So those are also a piece of the program that we work on. And again, we pick things that are important to you. So in the next slide, you'll see an example. So if your goal of your hierarchy was that you wanted to be able to continue to make meals and prepare dinner for your family, you would break that down into a number of different subtasks. So one might be opening the refrigerator door and pulling out the ingredients that you're going to need. Another might be gathering the knives and the peelers and the other pieces of equipment that you need in order to prepare the food. A third step might be being able to stir the pot on the stove, or to be able to lift a pan and put it in the oven. And then the final piece might be able to serve and carry those plates that you've prepared in the kitchen to whatever table you're going to be eating on. So you can see for those hierarchy tasks, they have multiple subtasks that are part of them. And in the treatment session, you'll work on each of those different subtasks to improve their ability to perform it. And in the end, you'll be able to do the entire task. And again, while you're working, the therapist will be changing the environment that you're working in to make each task a little bit harder so that you'll do it really well. Next slide, please. So in thinking about calibration, which is our goal, we ask you to self-critique. So you're constantly engaged in how you're doing. So we ask you, how much effort did it take you to reach for those ingredients and put them onto the counter? And when you do it in a big way, we're going to remind you that's the sensation that you should have each time you pull those foods out of the refrigerator. How much effort did it take you to stir that pot? That's the amount of effort that you're going to need. So we ask you to constantly tell us and think about learning the task, not just motorically, but kinesthetically. So we want you to know what it feels like to use your bigger efforts to get things done. And the next slide. The very last part of our program or our treatment session is big walking. And this is where we ask people to use a normal arm swing with normal stride length. So initially we might ask you to make a big arm swing and big steps. And as you go through, it's going to generally shape itself down into a normal gait and a normal big step, just like you saw with Bernie. His pictures on the left-hand side were very small steps with almost no arm swing, and on the right-hand side you saw big steps with a good normal arm swing. So while we call it big arm swings and big steps, we don't want you to look silly or awkward. We're just trying to get you to produce a normal stride length with a normal arm swing with normal posture. And it does feel awkward at first, and patients begin to feel like they look kind of silly. But we use a lot of videotaping to show people what they look like without the cued big walking, and then we use the videotape to show them how great they look when they do the cued big walking. And so it's just a wonderful thing to see, and it's wonderful for patients. They see a lot of huge, very important changes. The other part of the treatment session is what we call carryover exercises. So every day that you see the patient, and every day for the 30 days in the month that you're treating your patient, they'll be given what we call carryover exercises. And these exercises are little things that are designed to help them use their bigger movements in a real life situation, away from you, the therapist, and away from the treatment setting. So it's very difficult, but for them to do it, so as the therapist, you need to make sure that what you're assigning them or asking them to do is something that they're going to be successful doing. So for example, I typically will say to my clients, so what are your plans for the rest of the day? And often it'll be, we're going to go grocery shopping. So I would say to the person, if this is the first or second session, okay, I want you to get out of the car big. I want you to walk to the grocery store big, and until your spouse or whoever's with you notices. I might say, while you're in the grocery store, I want you to reach up big for a can off that shelf and put it big into the cart so that your significant other or partner will notice. And when they get that feedback about how well they did, that really helps to motivate them to keep going. So carryover exercises are really specific, and you're accountable for making them do them. So typically I will write it down in their chart what they're supposed to do and write it down in my chart. So the very first thing I ask them the next day is, hey, how did it go when you were at the grocery store? Did your wife notice that you were using bigger movements when you got out of the car? Did she notice that you walked up bigger and held the door for her? So you give them an assignment, a carryover assignment every day for 30 days, and then you get them to tell you about it. And it's really neat because by the end of the treatment sessions, they're really excited about how well they're doing. Next slide, please. So again, this next slide gives an example of, for the first week, when you leave the clinic, walk big to your car with your spouse and walk big enough so that they comment about your walking. So what you're looking for is to put them in a real world situation where someone will notice and give them some feedback about it. By week 3, you might be having them go to a restaurant with their family, open the door big for someone, walk to the table big, and sit down big, and use your big posture when you're ordering and sitting throughout the meal. And typically clients will come back and say, people, my friends said, wow, you look really healthy, or there's something different about you. And that's just such a great thing for them to hear and a great thing for you to see. Next slide, please. So the LSVT Big treatment goal for people with Parkinson's is that they will use their bigger movements automatically in their everyday living, and that there will be a long-term carryover of increased amplitude. As a therapist who's been working with this population for several years and as a PT for over 40 years, this is just an amazing thing for me. Previously, when I worked with patients with Parkinson's disease, I never saw much improvement. Typically, all I was doing was working with them to help them compensate for their loss of function. LSVT rocked my world because I've seen patients get better, and the enthusiasm that they have for getting better and continuing to work hard to maintain that function has just been awesome. So I hope that you will all appreciate and have the opportunity to work with clients. Last slide, please. So we know the advances in neuroscience have provided both the neurobiological and the behavioral evidence that supports the positive impact of exercise-based protocols for people with Parkinson's disease. And there is a huge literature that's growing in both physical therapy for humans and for animals that shows the impact of exercise for Parkinson's disease. LSVT programs have been developed and studied over the past 25 plus years, and LSVT Big is just one of those therapies that has the potential to offer improvements in movement and quality of life for patients with Parkinson's. I sincerely believe that anybody with Parkinson's disease deserves a chance at LSVT Big. It can impact their lives in a very positive way. Thanks for allowing me to share this time with you. I'm going to turn it back to Laura.
Thank you, Beth. That was just great information that you shared with us. If you are a person living with Parkinson's, briefly going to give you some information here. If you're interested in receiving LSVT Big, it's a very simple process. Simply ask your doctor for a referral to physical or occupational therapy for evaluation and treatment. If you want to receive LSVT Big specifically, go to our website, lsvtglobal.com. There's a tab called Find a Clinician. You click on LSVT Big. You can put in your search criteria. I would suggest putting in your zip code only and your search radius. You can search up to 90 miles around you to find LSVT Big certified clinicians in your area. And then you can have your physician direct that referral, fax it, email it, whatever, however they send it to that specific therapist. And they can evaluate you and determine if LSVT Big is an appropriate intervention for you. We do have DVDs called LSVT Big Homework Helper DVDs that are useful in keeping you motivated to do the exercises on a daily basis during treatment and also after treatment when you don't have that therapist there with you 4 days a week to encourage you. So those can be found on our website and through Amazon.com. We do have a German version available as well. If we have any German listeners in our audience, please email us. For further information, we talked about the webinars already. Please go to our website under patient resources and there's a whole host of recorded webinars. In 2016, very shortly, we'll be posting upcoming live webinars as well. There's also a program that we're going to develop in the spring of 2016 called Big for Life. You'll see here on the bottom. So if you have already received LSVT Big and are looking for a group to join to help you maintain your treatment effects, this is what Big for Life is going to be all about, is a post LSVT Big type of maintenance program, and we're very excited for it. So stay tuned on our website to learn more. We leave you with a quote from Sharon Ka, who has Parkinson's, and she's a very strong supporter of the LSVT Big and LSVT Loud treatment protocols, and she had great treatment effects from them, and wanted to share this quote with you, that it is possible to take charge of your life even with Parkinson's disease, and it is possible for your will to override your brain, and it is possible to have power over Parkinson's. So that is the hope that we wish to share with you today. Whoever you are, is that sometimes having a diagnosis of Parkinson's can be scary and leave you without hope, but there's much hope through the amazing science and research that we are continuing to find on how exercise and rehab can really make an impact in disease progression and disease function in people with Parkinson's disease. So with that, we're going to open it up for a couple of questions. Beth and I will stay on for a few minutes. I do realize that we're at the hour, and so if you have to log off and go about your busy day, feel free. We thank you for joining us today. We hope this webinar was really helpful for you. Again, if you have any questions, you can also email them to info@lsvtglobal.com anytime, and we will email you a response to your question. If you have future webinar topics that you'd like us to consider, please also email us. We'd be happy to hear that. All right, there is one person with your hand raised, and I'm sorry if I'm saying your name incorrectly, but it looks like Fawaza Al-Shamari. You have your hand raised. I'm going to unmute your microphone. And do you have a question that you'd like to ask us out loud? You can do so now. Okay, I'm not hearing you, so either your microphone isn't working or something, but feel free to type in your question. Okay, I don't see any other questions right now. And out of respect for your time, we're going to close the webinar today and bid you adieu. Thank you again for joining us, and we look forward to many more webinars in 2016.